coordinated by Professor Franz Schäfer from Heidelberg. The topic of today is clinical implications of genetics in children with nephrotic syndrome, and it will be presented by Olivier Boyer from Paris. My name is Elena Levchenko. I'm a pediatric nephrologist from Belgium, and I will moderate this webinar from my office in Leuven. During the webinar, the slides will be projected, and you can send your questions actually at any moment during the webinar. And there will be also some poll questions for you during the presentation. So try to be attentive and to answer all these questions very well. The webinar will be also recorded, so the slides can be seen later on the website of the ERKnet. So our speaker of today is Professor Olivier Boyer from Paris. She is a pediatric nephrologist at Necker Children's Hospital and is a full professor of pediatrics at Paris University in France. Following her training in pediatric nephrology fellowship in Paris, she completed a clinical research fellowship at Children's Hospital in Boston, Harvard Medical School. She also obtained a Master of Science degree in physiology and a PhD degree in genetics. Her main topic, as you know, is treatment of nephrotic syndrome together with pharmacokinetics of orphan drugs in renal diseases. Olivia has been elected as ESPN and also IPNA Council member, and is also a chair of the ERKnet working group on hereditary glomerulopathies. This year, Olivia also received a very distinguished award from IPNA, which is René Habib Award for the Outstanding Young Investigator. Before the webinar, Olivia specifically asked me to stress that she's a pediatric nephrologist and not a geneticist. So if you have some very specific questions about certain mutations in some genes, might be better to keep these questions for your colleagues in the genetic department, and otherwise you can ask questions and they can be transmitted. So now I think I can finish my introduction and give a word to Olivia. So Olivia, please, the floor is yours and we are eager to hear your talk. Thank you.
So many thanks, Elena, for this introduction. So as you know, most children with nephrotic syndrome are steroid sensitive and may present a relapsing course. However, 10 to 20% will not respond to steroids since onset, and an additional 3% will become steroid resistant after a period of initial steroid sensitivity. And in this subset of patients, the risk of end-stage kidney disease is up to 60%. You may also know that idiopathic nephrotic syndrome may have two underlying mechanisms. One is an alteration of the immune system resulting in production of a circulating factor of glomerular permeability yet to be identified. Patients are usually steroid sensitive or resistant but may respond to intensified immunosuppression, or are multidrug resistant and have a risk to recur after renal transplantation. To date, no monogenic cause has been clearly identified in these patients, including in familial forms. The second mechanism is hereditary nephrotic syndrome due to mutation in structural genes of the glomerular filtration barrier. Patients are typically multidrug resistant, although partial remission may be observed with CNIs, meaning reduced but persistent proteinuria. Nowadays, more than 50 genes have been identified that, if mutated, are responsible for monogenic forms of the disease. Most of these genes encode proteins expressed in the podocyte, a fascinating octopus-like cell with interdigitating food processes that encircle the capillary loops. These genes have various functions, such as encoding transcription factors, mitochondrial proteins, but mainly encode structural proteins of the slit diaphragm, as well as regulatory and actin-binding proteins. The outline of my talk today will be to try to convince you of the clinical implications of genetics in nephrotic syndrome, to help us making a diagnosis and ruling out differential diagnosis, identifying potential syndromic forms with specific management, providing genetic counseling, adequate therapeutic management, helping discover personalized treatment, and evaluating the risk of recurrence after transplantation and selecting potential intrafamilial kidney donors. So now, Tanya, you can send the question poll. So to you, what is the proportion of children with steroid-resistant nephrotic syndrome and identified causating mutations by the next generation sequencing techniques available to date? So the majority is right, 25 to 30%. Okay. So in the largest series of targeted next-generation sequencing published to date, almost 2,000 patients with steroid-resistant nephrotic syndrome manifesting before the age of 25 years were tested, and a monogenic cause was identified in almost 30% of patients and half in case of consanguineous families. And notably, the proportion of mutated patients was negatively correlated with the age at onset, with 2/3 of children with congenital or infantile nephrotic syndrome being found mutated, as compared to 10% in patients diagnosed after 12 years of age. A subsequent study from the same group of Friedemil Brandt in Boston Harvard Medical School using whole exome sequencing in 300 families yielded similar results, with 25% of families being identified with causative mutation. Now, as you know, the hereditary kidney diseases are schematically classified into different subgroups. First, the congenital abnormalities of the kidney and urinary tract and polycystic kidney disease characterized by abnormal kidney ultrasound and low molecular weight proteinuria. Second, the tubulopathies characterized by ion perturbances and low molecular weight proteinuria. The ciliopathies, such as nephronophthisis, characterized by urinary sodium loss, polyuria, and low molecular weight proteinuria, and glomerular diseases, such as steroid-resistant nephrotic syndrome or Alport syndrome, characterized by albuminuria, sometimes associated with hematuria. So the second question for the poll, which of the following diseases may present as steroid-resistant nephrotic syndrome with FSGS lesions on kidney biopsy? Note that this is a multiple choice question, so you may check all that apply. So the good response was all of them, as we will see on the next few slides. So recently, a new concept has emerged from experimental studies, showing that albuminuria is greater than previously thought. The albumin filtration across the glomerulus and the proximal tubules is greater than previously thought. And we now know that a large amount of this albumin is filtered and reabsorbed thanks to the megalin-tubulin complex. And therefore, tubular dysfunction may lead to heavy albuminuria. And the second concept, which is not novel but should be borne in mind, is that all nephropathies may eventually evolve to FSGS lesions, which are non-specific lesions associated to albuminuria. And therefore, in theory, heavy albuminuria can occur in all chronic nephropathies. And indeed, through next-generation sequencing, more and more non-podocyte gene mutations are identified in children referred to genetic labs for steroid-resistant nephrotic syndrome, or FSGS, such as PAX2 mutations, thus far known as a cause of acute and papillorenal syndrome with optic nerve coloboma, recently identified in 4% of adult-onset familial FSGS and no extrarenal features, diagnosed mostly from the second to fourth decades. In this series, the kidney ultrasound in patients could be either normal or reveal echoic or small kidneys or dilated pelvis. Similarly, tubular genes are found mutated in patients with albuminuria and FSGS, such as tubulin mutations, known as a cause of megaloblastic anemia, and OCRL and CLCN5 mutations, known as a cause of dense disease, that may also lead to chronic albuminuria and FSGS. Similarly, TTC21B mutations, known as a cause of nephronophthisis, were found unexpectedly mutated in families with isolated steroid-resistant nephrotic syndrome in adolescents and young adults, who displayed on biopsy both FSGS lesions and severe tubulointerstitial lesions suggestive of nephronophthisis. And the last example is collagen 4 gene mutations, known as the cause of Alport syndrome, now found mutated in 10% of autosomal dominant steroid-resistant or FSGS families with no known deafness before the genetic testing. So these data completely modify our understanding of hereditary kidney diseases and emphasize the need to include these genes in any genetic testing for steroid-resistant nephrotic syndrome, since it has clinical implications on investigation of extrarenal associated features such as coloboma or deafness, and on treatment, as we will see in the next slides. So as I said, the second clinical implication is to identify potential syndromic forms that are not always clinically obvious and may have a specific management, such as Schimke syndrome that associates spondyloepiphyseal dysplasia with short stature, strokes, and immune deficiency. And indeed, these patients should not be given immunosuppressive drugs for a long period of time. One of the best examples is WT1. Heterozygous mutation of WT1, mostly de novo, are associated to a wide spectrum of autosomal dominant phenotypes, including Dennis-Drash syndrome, associated male pseudohermaphroditism, susceptibility to Wilms tumor, and diffuse mesangial sclerosis, and Frazier syndrome, associating male pseudohermaphroditism, susceptibility to gonadoblastoma and strict gonads, and FSGS. These syndromes are related to exon 8 and 9 mutation for the Dennis-Drash syndrome and specific splice site mutation in exon 9 for Frazier syndrome. But they are also identified in 5% of girls with non-syndromic steroid-resistant nephrotic syndrome, and also more rarely in males. And very surprisingly, through next-generation sequencing, WT1 mutations were identified in pedigrees with isolated autosomal dominant steroid-resistant nephrotic syndrome, diagnosed in the second or third decade, including males without genital anomalies or tumor who transmitted the mutation. So these patients should have their kidney ultrasound monitors every three months, and girls should be prescribed a karyotype to determine their molecular sex. So now this is a 17-year-old girl whose nephrotic syndrome started at 15-year-old and who complains of primary amenorrhea. So what was done was a karyotype yielded a 46XY karyotype, and the search for a WT1 mutation who revealed a Frazier mutation. So what are the clinical implications in this patient? So this is, again, a multiple choice question, so you can check all that apply. Yes, so right. So refer to an endocrinologist for the amenorrhea, to a surgeon for gonadal removal because they're not working and they can have tumor. The ultrasound should be checked every 3 months. You can refer to a psychologist for the sex reversal. And this girl has a risk of having a child. Well, this is a dominant disease, but since she will not be able to have kids, she will not have a risk of having an affected child with her own ovaries. But anyway, so now the same girl has the same Frazier mutation, but a normal puberty and a 46XX chromosomal sex. So now what is the genetic counseling in this patient? Right, so this is a dominant disease. So she has a 50% risk of having a child with steroid-resistant nephrotic syndrome. And even if she only had isolated steroid-resistant nephrotic syndrome, transmitted this Frazier mutation, she has a risk of having a child with the complete phenotype, meaning a risk of gonadoblastoma, more rarely Wilms tumor, and a child with pseudo-hermaphroditism or male to female sex reversal. So of course, genetics can help providing genetic counseling. Most gene mutations in nephrotic syndrome have an autosomal recessive inheritance with unaffected parents and more frequent diseases in consanguineous families, such as NPHS2 mutations encoding podocin, which are the first cause of steroid-resistant nephrotic syndrome, or NPHS1 encoding nephrin, which mutations are the second cause. And more rarely, an autosomal dominant pattern of inheritance with one affected parent transmitting the disease, although incomplete penetrance is frequently observed. However, I will show you that genetic counseling can be far more complex than expected. Indeed, for instance, NPHS3 encoding PLCE1 is found mutated in patients that have either a congenital nephrotic syndrome or steroid-resistant nephrotic syndrome later during childhood with lesions of FSGS or DMS. And the peculiarity of the mutations of these genes is that although of recessive transmission, they may have an incomplete penetrance usually observed in dominant diseases. Therefore, in several families of our cohort and in the literature, a relative carrying the mutation in the homozygous states is asymptomatic, such as in this pedigree, the father of these two kids who are in end-stage kidney disease at 17 months or 3 years of age, and who is carrying the mutation at the homozygous state, and is completely asymptomatic with no proteinuria at 46 years of age. And these informations are crucial for genetic counseling provided to families, since we cannot predict whether another child or fetus carrying the two mutations will be affected or not. The second gene with a complex pattern of inheritance is NPHS2 encoding podocin. Corinne Antignac in our lab identified NPHS2 mutations as the most frequent cause of autosomal recessive steroid-resistant nephrotic syndrome, manifesting around 4 years of age and eventually leading to end-stage kidney disease by 10 years of age. NPHS2 encodes podocin, an integral membranous protein of the slit diaphragm that homodimerizes at the C-terminal domain. Most mutations provoke a retention of the podocin in the endoplasmic reticulum inside the cell, as opposed to being correctly targeted at the plasma membrane. And I would not go into too many details for the sake of time, but it is important that you understand that not all combination of mutations are pathogenic with NPHS2. Indeed, the PR229Q variant, which is a frequent variant observed in 3% of the general population, is only pathogenic when associated with a specific mutation of the C-terminal domain, which lead to a disrupted homodimerization of the protein, a pathogenic dimer, a retention of the podocin inside the cell, and the patient is affected with steroid-resistant nephrotic syndrome and FSGS. And this was nicely showed by Kalman-Torrey from Budapest and our lab. On the opposite, N-terminal mutation do not lead to any pathogenic dimer, so that the podocin can be correctly targeted at the plasma membrane and the child is unaffected. And this has important clinical impacts since since the association of R229Q variant and these mutations do not explain the nephrotic syndrome, and the patient may have an immune form of the disease and respond to intensified immunosuppression or recur after transplantation. But this is a good news, for instance, for this couple with an affected relative who would transmit an N-terminal mutation in one allele and the PR229Q in another allele, and who are not at risk of having any affected child, even if transmitted the two pathogenic alleles. But this is bad news for geneticists and clinicians, since it calls into question the Mendelian laws and greatly complexifies the genetic counseling to provide to patients. Now, what about treatment? So schematically, the current protocol, even if it differs from teams to teams and countries to countries, is to give to the patient 4 to 8 weeks of steroids and sometimes methylprednisolone pulses. And in case of no remission, the child is defined as steroid resistant. Kidney biopsies are indicated in most cases to exclude differential diagnosis, and the genetic analyses are started. And if the genetic analyses are negative, or if they take some time in some countries, the children are started with calcineurin inhibitors and alternate day prednisone. They may go to complete remission and have no relapse or relapses that are often steroid sensitive, or do not respond to immunosuppression to this protocol and may be prescribed intensified immunosuppression. that sometimes do not work, and the patient have to be given supportive care and progress to end-stage kidney disease. And in case of genetic cause, since most of the children do not respond to CNIs when they are mutated, well, the CNIs should be stopped and the patient should receive supportive care only. However, a question remains is that this patient with genetic mutation could benefit from cyclosporine. And indeed, complete response has been described in few patients with genetic steroid-resistant nephrotic syndrome, because cyclosporine has not only immunosuppressive effects by downregulating the transcription of cytokine genes and inhibiting the proliferation of T cells and B cells, but also a direct antiproteinuria effect by altering the glomerular hemodynamic and blocking the calcineurin-mediated dephosphorylation of synaptopodin through regulation of raw GDPases. So this question was assessed in this German retrospective study of 231 patients, in which Steffi Weber observed 78% of complete or partial remission in non-mutated patients versus 17% of partial remission only in mutated patients. And this is of major importance, since 2% of the patients reach end-stage kidney disease in case of complete remission versus 33% or 53% in case of partial or no remission, and 74 or 80% in case of partial or no remission in genetic patients, as opposed to 2 patients who entered into complete remission despite a genetic mutation and who had normal kidney function. So therefore, achieving complete remission is a very important goal. And in view of the poor prognosis of steroid-resistant nephrotic syndrome, some authors advocate that it is reasonable to propose a trial of CNIs, especially waiting for genetic analysis. And in case of complete remission, the question remains, should this patient continue the CNIs or not? However, this has to be balanced with the significant burden of prolonged exposure to CNIs with nephrotoxicity, gum hypertrophy, and hyperpilosity. So alternative treatments are needed. So this question really remains open. Should patients with mutation receive a trial of CNI? And in case of complete remission, what should we do with this treatment? On another hand, ACE inhibitors may not be necessary in all patients. For instance, tubulin mutations are responsible for Ehlers-Danlos syndrome, leading to megaloblastic anemia and proteinuria. Frequent tubulin variants are also associated with proteinuria and GWAS. And Matthias Simons from our lab identified 49 biallelic tubulin mutations in patients who were referred to the lab for suspected genetic SRNS or Alport syndrome or CACUT or PKD or tubulointerstitial nephritis, and identified that in another cohort from Germany. And in 11% of patients referred to our lab for chronic proteinuria. The average age at onset of proteinuria was 11 years. The patient had a chronic albuminuria ranging from 0.5 to 3 grams per day with more than 50% of albumin and minimal change disease on biopsy, and normal kidney function during childhood, and then were lost to follow-up in most cases because they were going very well. So most of these patients had received ACE inhibitors with no effect, and that leads to the question of, are ACE inhibitors indicated in those patients? And this was the work of Mathilda Bedin, directed by Matthias Simons during her PhD thesis. And as I said, a high amount of albumin is filtered by the glomerulus and then reabsorbed in the proximal tubule thanks to the tubulin-megalin complex under physiological conditions. But when the glomerulus is damaged, for instance, with steroid-resistant nephrotic syndrome or Laporte syndrome, a large amount of albumin and high molecular weight proteins are found in the proximal tubule, leading to an overload of albumin in the tubulin-megalin complex, leading to tubular cell stress and tubulointerstitial lesions and chronic kidney disease in most cases. And in this case, ACE inhibitors may reduce the albumin overload and lead to nephroprotection. However, in case of tubulin mutation, the endocytic machinery is perturbed, therefore all the albumin that is filtered by the glomerulus is not reabsorbed in the proximal tubule and is found in the final urine, but there is no associated tubulointerstitial damage and the patient have a normal renal function. And therefore, even if we give ACE inhibitors to this patient, the albuminuria will not be reabsorbed and will go into the final urine, but will not damage the kidney. This also opens the door to new drug development in proteinuric kidney disease, because we can hypothesize that a drug that would target the endocytic machinery could reduce the proximal tubular stress and damage induced by the albuminuria related to other glomerular dysfunctions. But this has to be demonstrated further. So a paradigmatic example of personalized treatment guided by genetics is the coenzyme Q10. As you know, coenzyme Q10 is an essential component of the mitochondrial respiratory chains, which biosynthesis genes, usually mutation, usually lead to multisystemic disorders with neurological involvement. And steroid resistant has been reported with 4 of them: coenzyme Q2, PDSS2, coenzyme Q6, COQ8, now called ADCK4. And this is a crucial diagnosis to make, since coenzyme Q10 supplementation may improve the symptoms and in particular reduce the proteinuria in few case reports. As I told you earlier on, most NPHS2 mutation provoke a retention of the podocin inside the cell, and this has 2 major clinical consequences. First, the mutants retained in the endoplasmic reticulum lead to an earlier age at onset of steroid-resistant nephrotic syndrome at a median age of 2 years, as opposed to 10 years in case of mutation that lead to a normal targeting of the podocin at the plasma membrane. And the second consequence is that the search for therapeutic chaperones able to correctly localize the podocin mutants at the plasma membrane seems very promising in the near future to slow the progression of the disease. So one of the areas of therapeutic development in this patient is therefore to try to identify chaperone proteins able to restore the correct targeting of the podocin mutants at the plasma membrane in order to at least partially restore the function of the mutant protein and to reduce the severity of the disease. And this is already the case in other genetic diseases such as cystic fibrosis, in which drugs such as lumacaftor or ivacaftor can correctly target CFTR and reduce the severity of the disease. So to finish, what about transplantation? So as we said, patients with no genetic mutation have a high risk of recurrence after transplantation. And aiming to assess the risk factors for recurrence with Moin Salem from Bristol, we identified 150 patients transplanted for SRNS between 1981 and 2012. From Necker, Bristol and London, and among them the recurrence rate after transplantation was 38%, with a double rate of post-transplantation complications such as graft loss, retransplantation, as opposed to the other patients. And interestingly, among the 25% with pathogenic genetic mutation or positive family history, none recurred after transplantation. Among the patients with primary steroid resistance, which were tested negative for gene mutation, half recurred, as opposed to 20% in the patients who were not tested for genetic mutations. And in patients with secondary steroid resistant, meaning initial steroid sensitivity, the recurrence rate was up to 95%. So therefore, we identified two major factors predicting the risk of recurrence. One is a genetic origin, which predicts a very low risk of recurrence of steroid-resistant nephrotic syndrome after transplantation. And the other one is initial steroid sensitivity, which predicts a very high risk. And therefore, the patient can be stratified, where possible, into circulating factor disease determined by an initial response to immunosuppressive drugs with a predicted high risk of recurrence. And this patient could potentially be treated with intensified immunosuppressive protocols to prevent the relapse, as opposed to genetic disease determined by genotype, family history, extrarenal anomalies with a low risk of post-transplant recurrence. And this patient could receive a standard immunosuppressive regimen and be spared potential toxic drugs. And of course, in these cases, the genetic results should guide selection of unaffected donors. So to conclude, I hope that I have convinced you that the genetics have major clinical implication in nephrotic syndrome to help us making a diagnosis, since some non-podocyte-related diseases may mimic steroid-resistant nephrotic syndrome, and to search and follow extrarenal features associated with the disease, to provide genetic counseling in monogenic diseases with the issue of incomplete penetrance even in autosomal recessive diseases, and the issue of interallelic influence of mutations with NPHS2 mutations, to avoid inefficient immunosuppressive treatments with potential side effects, but we don't know what to do with the complete remission induced by CNI in a subset of mutated patients, and to discover personalized treatments such as coenzyme Q10 substitution or maybe anticubulin or chaperone molecules later on, to predict a low risk of recurrence after transplantation and select potential intrafamilial kidney donors. I would like to thank all my colleagues and friends from the Imagine Institute in Paris, and most importantly, Professor Corinne Antignac, who is in charge of all the genetic studies and research, our collaborators, and especially Beata Lipska from Gdansk and Franz Schaeffer in Heidelberg, and Frida Mindoblant in Boston. And I thank you for your attention.
Thank you very much, Olivia, for a very, very nice overview. I think everybody is very much convinced that genetics are very important in patients with steroid-resistant nephrotic syndrome. Please ask questions. I have already one comment from Julia Hofeler. So the comment is, if the mother has R229Q mutation, the child has still an increased risk compared to their population, as the father could carry another pathogenic variant in NPHS2. We do not know the allelic frequencies of recessive nephrotic syndrome genes in the general population. Can you comment on that?
So the question, I guess, is that should we test the father?
Yeah.
Well, I think the allele frequency of other mutations is pretty rare. However, I guess that if the patients, if the couple is very stressed about that, it is indicated to test the second parent.
Mm-hmm. Yeah, I agree actually. Well, other questions are coming. Can we ask you also you suggested the intensified immunosuppressive protocol in patients with recurrence. Can you comment on what kind of protocol would you use? Most of the kids would already receive immunosuppression with steroids, CNI.
Yeah. So there are not very large studies assessing the efficacy of intensified protocols, but there are few case reports of the efficiency of plasma exchanges or immunoadsorption combined with rituximab or that kind of immunotherapy. I know that there is a recent trial suggesting that rituximab is not efficient, but it's also a retrospective study, if I remember correctly, with a few patients. So for the moment, what we do in our team is that if really the patient has been initially steroid sensitive and we believe that there is a 95% risk of recurrence, we would do preoperative plasma exchange or immunoadsorption and rituximab in the OR and 1 week after. If it's a primary steroid resistance with no genetic mutation, where the risk is it's closer to 50%. So what we would do would be to wait for the recurrence, but as soon as the child has albuminuria, we would start IV cyclosporine and high-dose steroids. If in case it's not sufficient, we would do plasma exchange or immunoabsorption. So that's what we do.
Okay, thank you very much. In the meantime, other questions are coming. We have a question from Maria Elena Verbisch. So the question is, do you think a trial with calcineurin inhibitor should be done in every steroid-resistant nephrotic syndrome patient, independent if there is or not genetic mutation identified?
I think that is really the question at the moment in subset of patients. So for the moment in France, we do not have the result of the genetic testing before 1 or 2 months. So we that left us some time to give CNI and then to decide what to do in case of mutation. But I don't know how the colleagues such as in the UK or in Germany who may have the results in 2 weeks would do. I don't know. I know that Marina Vivarelli from the ESPN and ERK working group is trying to collect the cases of patients with genetic mutation who entered into complete remission to try to better describe these patients and maybe give us some advice on how to treat these patients. But for the moment, she hasn't collected a lot. So I guess that means that there are not a lot of patients who enter into complete remission with CNI. And that for the moment, I continue to believe that it is not indicated to give CNI to all of them, but we need more data to affirm that.
Okay, so we received some compliments from Mignon Makulak, who thanks you for a lovely presentation. Another question is from Christy Thomas. If there is any evidence of increased or improved kidney survival in monogenic steroid-resistant nephrotic syndrome patients? So do they have kidney survival after transplantation, I guess is a question for PS.
Oh, after transplantation, when it's a genetic disease, they have a very good outcome as in acute or other causes of end-stage kidney disease. The problem is that when it's not genetic and that they recur and that they can evolve to end-stage kidney disease again within few months or years. But if it's a genetic cause with no recurrence, they have a very good outcome.
Yeah, I fully agree. So Mignon Makulak from South Africa asks, in the low resource countries and actually no finances for testing genetics, how should you prioritize the patients for genetic testing?
Yes, we have discussed that when we work for the IPNA SRNS guidelines. I think there are two ways of seeing that. Either you want to identify the mutations in patients with suspected genetic disease, such as patients with a familial unaffected relative or syndromic forms, or you may say that these patients have probably genetic disease, so so it's not necessary to test them to be sure that they are mutated, as opposed to the patient with no family history, no syndromic form, and that you have no clue to know whether they are genetic or not. And this one, maybe it's more effective to test those ones. But I think it's debated, you know.
Yeah, yeah. So another question is from Ismail Dursun, who asks specifically about CD2AP mutation. He has a patient with novel CD2AP homozygous mutation, and he's questioning whether the whole story of steroid-resistant nephrotic syndrome can be explained by this mutation.
Well, I think it depends on the mutation. I know that, so I'm not a geneticist. I know that Corinne Antignac in our lab at first did not really believe into CD2AP mutations, because sometimes they have a dominant inheritance, sometimes a recessive. The mouse model has recessive inheritance and so on, but I know that we have at least one family with a truly pathogenic CD2AP mutation. So I guess it depends on the type of the mutation, how is it predicted as pathogenic or not by the softwares, how is it transmitted in the families, are the parent, do the parent carry the mutation, are they affected, and so on. So, you know, it really depends on the type of the mutation and on the bunch of arguments for pathogenicity of genetic mutations.
Yeah, thank you much. Yeah, we have also one family with a recessive CD2AP mutation was also described, and there were some cell biological studies done. So probably these patients exist, but it depends on the mutation. Yeah. Okay. So I was myself a little curious about the Kubilin paper and mutations. We have also tested Kubilin in a lot of patients because it's a part of the proteinuria panels, and we find a lot of polymorphisms in Kubilin also in the healthy population. So how have you identified the pathogenicity of this Kubilin variant?
Yes, for the moment it was only in silico with the softwares of prediction of pathogenicity and with the transmission of the disease in the parents and with the frequency of the variant and so on. But they haven't done for the moment in vitro testing of the mutation.
Yeah. Okay, thank you very much. One more comment from Julia Huffeler, who would just still recommend to call the common variant R229Q in Podocin, I guess, Julia, as a variant and not as a mutation. I think it's correct. It's a variant as long as it's not associated with a mutation. When
sure, it's a variant. It's a frequent variant, and once again, it's very important to stress that it's not pathogenic with all associated mutation on the second allele. So,
okay.
So that there is a lot of work for geneticists like Julia, and we really need them to take care of the patients.
Okay, no, she actually means all mutations, but I think it's a question of the nomenclature. So it's a difficult discussion, I guess. So another question is, I have to check from Dr. Sadaf Asim. Kindly comment on presence of collagen mutations in nephrotic syndrome.
Yes, so more and more collagen 4A3 or 4 mutations are now found in patients with autosomal dominant forms of steroid-resistant nephrotic syndrome or FSGS, and in particular in adolescents or adults. Now it is one of the first identified genetic cause in adolescents and adults. And usually these patients are referred well, are classified as FSGS with only proteinuria, and it's not known that they have hematuria or deafness. And when you go back to the charts, sometimes they may have microscopic hematuria, and sometimes they may have deafness, but not in most patients. So now these mutations are really associated to steroid-resistant nephrotic syndrome or SRNS, and not only to Alport phenotypes.
Okay, thank you very much. I think you answered all the questions. And I really would like to thank you once again for a very good presentation. We learned a lot, and thank you, the audience.
Thank you, Elena. And I have to introduce the next ERKNet webinar, which will be run on December 3rd, 4 p.m. by Olivier Lidov from Paris Hôpital de la Croix Saint-Simon on Fabry disease, the new great imposter.
Thank you very much. The webinar is closed. Good evening, everybody.
Thank you.